healthcare business podcast from the Coker Group that focuses on solutions to help healthcare organizations effectively navigate the changing healthcare industry landscape.
Welcome back to another episode of Coffee with Coker. My name's Mark Rybolt, and today we have some new guests with us, and I will introduce you all to them shortly. Before we do that, I just wanted to, like we always do, mention a couple of housekeeping items. Want to remind everybody, first of all, that if you are interested in this episode and the other episodes that we have that are similar to this, we encourage you guys to visit coffeewithcoker.com. That is where all of our episodes are available, as well as other content that is published by Coker, and a lot of good information there. So you can find that again at coffeewithcoker.com or at cokergroup.com. And as always, we just encourage our followers to subscribe, and you can listen to all of our podcasts on all the podcasting platforms, and follow us on social media as well. But with that, I'd like to go ahead and jump right into the discussion. So today we have two ladies from a company called Cordata Health. This is something that's kind of different probably from a lot of the things that we talk about, but absolutely connects with everything that Coker does in our work with our clients. But jumping right in, I want to welcome Dr. Kelly Firesheets, as well as Cam Teems. So ladies, welcome to the podcast.
Thanks for having us.
Thanks.
Absolutely. And we're looking forward to the discussion today. But jumping right in, instead of me trying to describe what Cordata does, Kelly, if you don't mind, just give us kind of the rundown of Cordata and what you guys do in the healthcare space.
Sure. So we are a technology company that's way more than a technology company. We're kind of a problem solving team. And we have a technology that goes along with that problem solving. And really what we aim to do is to create workflows and pathways that support people with really complex issues as they sort of move down the road to health. I'm going to start by saying that in vagary, because we work both inside healthcare and in the community and in that transition between them. But to give some real specific pieces of that. So in the community, we help first responders like fire, EMS, police, build pathways to better and more effectively respond to overdoses. So that if someone has an opioid overdose in the community, they can follow up with that person and they can give them the support that they need to help them get healthy, whatever that person means to them, whether that's getting to treatment, getting health care for some of the comorbid issues they might have because of their addiction, or even just getting connected to housing services or supportive services to keep them healthy. So that's a really specific example, but I like to think of it more broadly because we really are trying to help build new pathways across systems that help create holistic health for people.
Before we started recording, you made a comment about the I'll just word it this way, the intersection between community and healthcare. And sometimes we tend to think of those things as separate or mutually exclusive, but they certainly aren't. And that's something we at Coker kind of, I think, intersect with a good bit, but I really like the way you put it. Can you speak to that?
Yeah. So, and just for context, we were kind of going back and forth about Cam's role versus my role. Generally in the company, Cam speaks for our healthcare facing work and I speak for the community facing work. But I think we all know just as human beings, right? Like the healthcare is the community, right? And community is part of healthcare. Very often we act like they're really different places, different people, different systems. But to you or me as a patient or a recipient of healthcare, it's one and the same. And so what we want to see happen is we want to see these systems out in the community and the systems in healthcare working together to create healthy people.
Cam, maybe talk about, so how is, and we're going to probably circle around here to bounce around a little bit to a couple different topics here as far as what Cordata does. So I certainly want to get into that more specifically, but how does this connect to healthcare specifically, or how is it related to healthcare, Cam?
So, as Kelly said, those people out in the community who are engaging with law enforcement or seeking help for connection to resolve homelessness, those people are also, presenting to their local hospital or healthcare providers with a high-risk pregnancy or with diabetes or with cancer. Or they are, if they're in an active addiction, they are seeking pain medication, inappropriately through a pain center that's managed by a hospital or a health system. So they're constantly, interconnecting with each other and through emergency rooms and individual, physician practices. And so what Kelly and I aim to do in our grand plans, right, is to bring that understanding together, that, as Kelly said, that person out in the community, that, that high risk pregnant woman who's on Medicaid, who is, suffering from homelessness off and on, and she and is addicted. She is being touched by all of those stakeholders in healthcare and in care. And we just want everyone to realize they're all on the same team and they're not separate. The reason that we approached you to begin with, Mark, was that, Cordata wants to bring these two, really important stakeholders together, right? The people that are out in the community providing these deflection services, these people who are suffering, and we want the stakeholders that are in the glass buildings to really understand that they have a role here, right? And so, and Coker is a great resource for us to put this message out, and that's all of it.
Yeah, it's interesting when you're talking about no one, or most people are probably more and more intersecting with homelessness, addiction, mental health, whatever it may be, and I think we've particularly seen more of this, or it's become maybe a little bit more acute here in the last 18 or so months with the as COVID came in, and as we've still working to navigate through the pandemic. So it's front of mind, I guess, is my point, for many people, and in many communities, it's right there in front of them. So, I think it's interesting because I've heard people talk on this, and it almost seems like in some cases, in some communities, it's almost overwhelming. Like, what do we do? How do we, how do we resolve this crisis? And it's, is it a homelessness thing? Is it a mental health thing? Is it an addiction thing? Well, it sounds like, yes, it's all of the above.
Right.
And which can make it a little bit more overwhelming. But that's one of the things that I like as far as what you guys do and what you're talking about in terms of getting down to this at a community level to support these people, these patients that are going through these various situations of mental health. Kelly, you're a clinical psychologist, right? And
training, yeah.
So, I have to think there's tons of discussion on this, but this is one of the first things that I've seen. I mean, one of the first companies I've seen that, brings innovation to the table. Can you walk us through a little bit as far as what Cordata does? How do you guys approach these challenges and ultimately work to resolve them?
I find myself saying a lot recently that I think the secret sauce is to work bottom up and top down. And I see really commonly, I think, in our attempts to change systems, we're doing one or the other, but we're not making them both work together. And I feel like that's really important, because when you try to implement top-down change in a system, and I can give some examples, specifically the opioid epidemic and what we've done. We've done the prescription drug monitoring systems, right? Where we're cataloging and we're looking at prescribing habits, and we're doing it. It's a really top-down kind of approach, right? Or we've changed prescribing guidelines, also a very top-down approach. We've had change guidelines around MAT or access to buprenorphine in an emergency department. It's like big systems change things, and that's critical, right? You got to do, we're aggregating data. We do so much data analysis on the opioid epidemic, combining data sets, hotspotting, all this kind of stuff. But until you can translate that to actual change, behavior change for people, individual people, you don't solve the problem, right? So I think we've gotten to a point in the opioid epidemic where we collectively can describe the epidemic. We understand what's needed to resolve the epidemic, but we're still struggling to figure out how to get those individuals to change their behavior, which, in healthcare is the challenge of any chronic condition, diabetes, heart disease, right? Like, how do we get people to change what they're doing? It's dang hard, right?
Mm-hmm.
And I think maybe that's where I see this differently, because I am trained as a clinical psychologist. And so what I learned was human behavior and you can't change people's behavior, but how to coach them through that process. I think that's really where Cordata's approach has been very different, because we've gone to places in the community where people are. When they're addicted, where are they? Well, they show up in the emergency department. They have run-ins with police or law enforcement. They, often are homeless or really sporadically housed. There's a lot of 911 calls about them. And so we go to places where they are, and we help those folks who are having pretty regular contact with these people start to learn how to coach them through that behavior change, and also to build that into a system or a network. The ideal would be that we've got a network of people all through the community, in and out of healthcare, that notices when people are addicted or at risk of becoming addicted, and that knows how to move them towards behavior change so that they can be healthy. And that's what we're trying to do. And again, it's cops, it's EMS providers, it's emergency departments, it's health departments. It's kind of a cast of unusual characters. And the goal is not to treat the addiction. That we've got great treatment providers for that, and a growing amount, like we're getting more treatment capacity nationally, but the goal is to sort of inspire people to get to treatment, remove the barriers as they go there, and then help support them staying in treatment and staying in recovery.
Yeah, this is interesting because Coker works with, and we have over the years, obviously everybody knows hospitals are kind of our main clients, as well as physician practices. But we work with a lot of community health entities, a lot of, on the practice side, a lot of pain, spine centers, those types of providers. And we've kind of from a distance in a certain way, or from perhaps a little bit different angle, have seen the opioid crisis and addiction and behavioral health treatments just escalate significantly in the last 10 years, as we all know. But one thing that is very much, well, before I say this, let me also say that there is not a hospital or health system that I can think of or imagine in the country that isn't working on this issue in one way or the other, or having to deal with this issue. Some are probably doing better jobs than others, but it is absolutely, without a doubt, on the radar of every healthcare entity out there, certainly on the hospital side. But one of the things that is very much outside of Coker's wheelhouse and is very interesting to me is what you guys talk about with pre-arrest deflection. Talk about that for a second.
Yeah, it's funny. It's funny to make the gear shift to arrest for deflection from healthcare, right? But it's such a small little step. And actually, I'll share with you the story of how I got here, because I think it's kind of representative of how this works. I was a researcher and an evaluator. I'm a data nerd. Like that's what got me here. Is I love data. I love information. I love taking data and solving problems. And I was responsible for measuring the outcome of all of these sort of community interventions for the opioid epidemic around Greater Cincinnati. And um, the interesting thing was, there were kind of two things happening. There was a movement towards getting more treatment, right? Get more treatment capacity. Mm-hmm. And that usually meant hiring people, starting new treatment organizations. There was a big push for medication assisted treatment, MAT. So that was happening. But then there was this other stuff that to me was far more interesting, which was there were all these first responders who at the time they had just bought into the idea of using naloxone. We'd gotten over the resistance to naloxone. But the first responders were saying, yeah, but this doesn't seem like it's enough. Like, it's great to administer naloxone for an overdose, but then don't we need to help these people because they overdosed? And there wasn't a clear pathway for that. What happens after you revive somebody with naloxone? And so they just started to do stuff. At first, they just did it on their own. They'd go back and visit the person the next day and say, hey, you kind of died yesterday. Could we help you? But then they'd get more sophisticated. And so they'd partner with health systems or peers or treatment providers and take them out too. And we started looking for what was happening everywhere, kind of organically, just happening. And I was trying to figure out how to measure it. But the first thing you have to do before you can really measure something is figure out what the heck it is, right? Mm-hmm. And so I went on this search and I discovered this whole field called pre-arrest deflection, which really is the idea of building systems where first responders or community networks can send people out of the criminal justice system even before they get in there, right? So the goal would be to not arrest people, but to get them somewhere else so that we can support them. And, I was kind of intrigued by this. And I would say, are we doing police reform? And folks would be like, shh, don't tell, right? The secret.
But under the radar.
But it really is also, and we talk about that more now, because there's a lot more interest, I think, and momentum around changing policing and the nature of the way we do criminal justice. So this really is this fascinating systemic intersection of healthcare, of behavioral health, and of criminal justice. And it all sits at this point, again, of let's figure out where these people are and how do we support them when it becomes known to us that they have a problem. Whether they present in healthcare, whether they present to law enforcement, whether they present, in a housing situation or some other social service situation. Let's all work together because our shared goal of getting them the right services, it benefits all of the systems. But by the way, our systems aren't designed for that at all. Nor are our payment structures, right? It's a whole learning curve to figure out how to work that way. But personally, I love the challenge of that and the experience of making it work and seeing these programs kind of take flight is pretty cool.
Yeah, that's really intriguing to me, and of course, this is not my area of expertise in saying this, but I have to think that's probably something that would be embraced by law enforcement as well, because I think in the majority of the cases, they see that this systemic issue here is not sustainable, and they, I think, a lot of times don't want to have to go through kind of the traditional process of whatever it is, incarceration or whatever it may be, at that kind of pre-arrest level. So, and as well as for the healthcare providers, because like you said, I mean, it's at that point, it's almost too late because, whatever it may be, if it's an indigent care situation or whatever, getting it as early as possible, I have to think is kind of the natural or optimal scenario.
Right.
What can we do as far as hospitals? If I'm a hospital or someone in a hospital and thinking about, all right, how do we get ahead of this? Cordata could be a solution to help us do that. What needs to happen there? What can hospitals do better? And where do you guys come into that process?
First, I would say that it's the awareness. And of course, that's why this conversation is so well timed. We have a fair amount of, innovative hospital CEOs and health system executives who see what Kelly just described. They have, either stood at their emergency room doors and said, look at all the police cars that are here, and look at the police and fire who are standing here in our emergency rooms. What is this connection that we need to better understand? So some of that's already happening, but the more we can help that conversation occur, where the hospitals and health systems realize it takes a village, not just them, but somehow connect with the community. We know that hospitals long term have understood that the community is who they serve, right? They do community needs assessments. That's who they are beholden to. Right. And this is just really the next step, I think, is it's not just taking them in for those traditional services. I think, sort of healthcare 2.0 or is to really understand that care is happening everywhere, and that your village is the people that you encounter in the hospital. It's your primary care provider. It's the ambulance drivers. It's police. It's the social workers, community health workers. As individuals, regardless of how sick you are, that you have access to a village that crosses all of those sort of physical boundaries. The glass building versus your home, in the street, wherever. That's what my answer would be. How about you, Kelly?
I think, and I've done quite a bit of work with hospitals. What I see is health systems are to the point now that they understand the intersection points, right? So the emergency room that's always the first thing that pops out, right? Like the emergency department, and then pain management. Usually that comes next, right? Their awareness of some of these intersection points. But I think where I've seen the health systems and hospitals that have done this really well are the ones that move it from being a program, here's our nice program, to the way we do business. This is our philosophy of business. And there are a couple of health systems that I've worked with that would even say, this is our market differentiator. We understand this. We think about it all the time. And yes, we're here to help your physical health, right? If you come in and you need surgery, we're going to help you get your body healthy. But we're also very aware of who you are as a person, and we're going to support you emotionally. We're going to support you to be a healthy person. And I think it's just appealing, right? It resonates with you on your insides of like, yeah, I want to be in that place. But I think there's also some real pragmatism of like, that is kind of in a world where we've got mental health issues that are escalating, and where the addiction is worse than it's ever been. That is probably actually a nice market differentiator to be able to say, we can help you be healthy. I think of every interaction, and if you think of a person who has an addiction or a mental illness, every interaction they have, any human interaction, has the potential to help them get a little bit healthier or leave them a little bit worse off. And I think if you think of the whole of healthcare interactions, there's real potential to do good for people in their emotional health and their behavioral health. If we think of all of those interactions strategically as trying to move people towards this broader goal.
It's interesting too, because we've all heard or observed, seen these scenarios of an individual that is struggling with addiction. And it almost is like it's so overwhelming to think about what they're going through that it's hard to even imagine how do you dig yourself out of that hole. And traditionally, I think, at least I, maybe others, have looked at it as kind of it's on them, it's on them. They can go to maybe rehab or a facility or, go through kind of the behavioral health treatments, those types of things. But what I'm hearing is from you all is that it has to be much more holistic, or it could be more holistic. And that to me is encouraging when I think about those individuals in those situations, because it's probably not in most people's scenarios one thing. And Cam, you mentioned the community health assessment, for instance. I think that's a great representation, which, by the way, that's something that Coker has done for 20 years for our clients and helped them with, and turn it into a strategic process of, okay, how do we think about these things differently? How do we think about serving the community differently? Because you do have an obligation, whether you're Mercy Health in Cincinnati or, a critical access hospital in rural Georgia or something, and everything in between. But when I think about, and I think nowadays we probably tend to go to like the examples of San Francisco or other major metropolitan areas. But the reality is this is something that happens in the smallest of towns up to the largest urban environments all over the country. But when I think about this idea of being more holistic, we've been talking about clinical integration and population health, community health for, going on a decade now, probably. It still just seems overwhelming. What are some things that you guys are doing with your clients that help kind of close this gap, if you will, or maybe it's the other way, expand the coverage, if you will? And when I say coverage, I mean the services that are provided, the resources available.
So when we start working with a community, I really, it is big and it is overwhelming. And so I actually really encourage people to start small, right? Like, let's start small. So, and I think I said this before, I think a lot of times people go in and they want to like, let's go through all of our data and look at, and I'm like, no, let's not do that. Let's hold off on that. Let's start small. Where do we know people are? Right. And so let's take the low hanging fruit. And so you start with the most obvious place. In a lot of our communities, that's real simple. That is getting lists from police or fire or both of folks who have overdosed, right? Like, let's just get the names. These are the people who have overdosed and let's go visit them, right? That's a pretty small world. Right? Like, it's a pretty small world and it's a pretty specific intervention, but we're going to go, we're going to meet them. We're going to talk to them. We're going to give them some support to hopefully help them get healthy, but also keep them from dying if they overdose again. It's, kind of a pragmatic intervention. Mm-hmm. Once people start doing that, it grows very naturally. And so we've seen communities that have started with that. I go out once a week and I visit everybody who overdosed in the past week. And now they're doing things like they have proactive engagement teams that specifically target African-American men because they're the most resistant to engaging in healthcare or treatment, right? And so those proactive collaborative teams, they're out in neighborhoods talking to people. We have kind of complex hotspotting programs where we look for people that are at risk of gun violence and who are mentally ill and who are homeless, right? And we work with those people. So it will grow. Like, you have to trust that it will grow. But I think very often communities, especially, they start really big with like the whole thing. And you need to start in one place with one population and then let yourself expand kind of as the course grows naturally.
One of the things that I've observed about Cordata is, and I said I would kind of try to bring this full circle, but if I'm a someone in a health system in a leadership capacity trying to, like you said, Kelly, figure out where to even start. But one of the things I've observed in reviewing some of y'all's information is some of the specialties that you drill down into. And we don't have to go through all of these by any means specifically, but you talk about bariatrics and cardiovascular, oncology, orthopedics, pain, spine, et cetera, a number of others, and which I encourage everybody to go visit you all's website to learn more, for anybody that's interested. But if I am one of those people and I'm thinking about how do we even start small, working with the community to close that gap, where do you all's solution kind of come in, and what does that look like? How does that work?
I think a lot of what we do is help people figure out where that starting point is, and then we really support the pragmatic workflows, right? So it's not just about identifying people, or it's not just about assessing people, or finding at-risk people, but then figuring out, and then what? What is the workflow? How do we support that person? What resources do they need? What's the criteria for follow-up? And then how do we make sure that we are monitoring all of that while people are out in the community? I mean, one of the things I think that is fascinating about this universe we're in is the people that we are all the most interested in, they're in all of our systems, right? But that means they're in none of our systems. So there's a little bit of data in the EHR, and there's a little bit of data in the HIE, right? It's trickled over, but then there's also addiction treatment data, and that can't be shared with anybody. And you got law enforcement data and jail data. They're in that gap between all of those systems. What we do technologically is fill that gap and try to understand what's happening, honestly, what these people are doing, in their actual lives when they're not inside one system or another system, and to understand how to get them more engagement with systems that can make them healthy, right, in a sustainable way, and less engagement in systems like law enforcement, in criminal justice and corrections, things like that. So we really, technologically, we try to create a workflow platform so that we can support people when they're not in any one place, but they're kind of in every place.
Well, and you guys are bringing a new layer of innovation. I'll just say, I think you kind of made this point, Kelly, and I would say we've been saying this for years. Listen, there's a lot of technology in the healthcare world. What we haven't done well in the healthcare world is figure out how to connect a lot of this different information, whether it's data, information like what you're talking about, or the actual technology infrastructure even. We do a lot of work in that space, and that's probably the disconnect is probably the biggest challenge that a lot of organizations face. And for, some are valid reasons, but you guys are even extended beyond the health system itself. Like you said, you're working with law enforcement or community health or another provider entity, whatever it may be. So I think that innovation it's not that the technology is is the most revolutionary part about it. It's the engagement and helping navigate that process.
Yeah.
How does that kind of play into what you guys do, that navigation piece?
I think the navigation piece is key. It really is key here. Sometimes people will come to me and say, "Oh, I want your system for, I want this data and this data." And I'm like, okay, to what end, right? Because again, though, we're going to solve this problem by supporting behavior change. And that navigation piece, building those networks of people who can support behavior change is the critical part of this. I think what we're able to do, because we work in this interesting space in the middle, is kind of leverage the strengths of each system, right? So healthcare is just data rich, and that's really valuable. On the other side, the law enforcement side, you have a lot more flexibility in what you can share, They don't have the same types of restrictions around data sharing. So from a collaborative perspective, for healthcare to have access to some of the information that law enforcement has on folks could be really valuable, and we can facilitate that, that kind of sharing. But again, always with the focus of how do we help that person, right? We're not going to share data just to share data or create a big catalog of everybody's information, but how do we use those data to really help inform the support we're giving people to get them to the right places?
Mark, I want to give you an example about, so you mentioned all the different typical complex diseases that Cordata has traditionally supported. So, our technology and programs, like Kelly was mentioning, it started in those complex diseases under the hospital roof, like cancer, bariatrics, cardiovascular, et cetera. So what was happening was those users of Cordata in that space, right, as Kelly called it, we leveraged the EHR's data for, let's say, the cancer patient. We leveraged the EHR's data, and the users of the Cordata system are typically have been those traditional disease navigators, either in cardiovascular or cancer, et cetera. So back to the cancer example, those cancer navigators using Cordata to really see the whole cancer patient. So take, for example, my cancer patient is maybe also suffering with a comorbid addiction. I'm managing her using my Epic or my Cerner data. I'm also putting in my own data that I'm discovering about my patient as I am intimately supporting her. But at some point, I want to talk to her village, but my EHR has an endpoint, and Cordata allows me to stretch and talk to maybe her outside social worker or somebody on a team that is going to help her when she's not under the hospital roof or the cancer center roof. And that's where we sort of stand in the gap in that traditional service line or disease program where we bring the two together.
One of those things, I mean, you talked about using data to solve problems, and it dawned on me that's one of the things Coker does for our clients in a different way, in a different realm, perhaps. Yeah. But when it really boils down to it, that's a lot of what we end up doing. And I think that is one of the things where, particularly speaking about hospitals as well as practices, and really all kind of provider organizations, there's a gap there. I think that many of them experience just because you are dealing with either you're typically, I think it's an abundance of data, maybe overwhelming abundance of data. Even if you can kind of understand the data, then figuring out what to do with it, I think, is where probably the biggest gap exists, for at least when we're working with our clients. It's not that they don't know what the problem is. I think we have an idea of what the challenge is here. It's where do we start, and starting small. Having that kind of solution to help navigate that, I think, is overwhelmingly helpful, beneficial for overcoming this challenge out there. What did we miss that I didn't? Is there anything that you guys wanted to mention that we didn't talk about?
Mark, I want to say this to you just to kind of, I don't know if this is worth having maybe one more conversation. I don't know if you guys ever do that, but one of the things that we didn't touch on that I think is of interest to, a CEO who's figuring out how to differentiate themselves, right, in this, post-COVID. I think one of the things that Kelly and I have, Kelly on we keep saying that, Kelly's side, my side, but we say, but it's the same. Sure. The people I've talked to versus the people Kelly's talked to. For example, a CMO at a university system hospital, and I were talking about this recently, and he said, it's an elephant, and I don't know how to eat the elephant, right? I've got to bite it, and I see all the things I want to do, and it's post COVID, and what do I grab onto? I've got my I'm the CEO. I'm sitting around the table with my marketing officer, my operations person, my chief nursing officer, et cetera. Maybe board members from the community also from the night before. And I'm trying to decide, where do we come down? What do we go after, right? The CFO is saying, we've got these reimbursement issues, this value-based care thing. What do we do? And because I had approached him and said, hey, look, overdoses are up, right? It is huge, right? Long COVID is, don't even go after that, really. I mean, you can, but really overdoses are the biggest, that and, kids who've been put into the foster care system. There are a lot of other big downstream effects of COVID that are huge. If you are a CEO who really wants to come out as a sort of mission leaning CEO. But he said, I don't know where to start, and I need somebody to tell me how to do it, right? That's a consulting thing. Kelly and I have both said that's consulting, right? We have the technology and some of it we can bring a programmatic, frame to, but they need the consulting, the hand-holding, the groundswell creation in the leadership, right? This is what we're going to do, and this is why.
Yeah, right.
Because I think a lot of people are sitting around those conference room tables right now going, what do we do next? Right? We can't focus on all service lines.
And there are so many things happening in the environment. The one I talk about every day now is the 988 rollout, the national 988 rollout. I don't know how this is going to play. I don't think it's very well conceived for a lot of reasons. I think the impact of this is there's going to be a lot of mental health crises dumped at emergency rooms, right? Like, I mean, that's which, again, I think out there in the world, people are like, well, just get them to the ER and they're going to take care of it. Right. And I know because I'm a psychologist, but I also know because I did consulting work with emergency rooms. Emergency rooms are no place to deal with a mental health crisis. It's like the last place actually you want to deal with a mental health crisis. But I think that's going to be the net effect of this as it rolls out. And so I think when I think about our health system partners, the ones that I feel like the most affinity for, I'm just like, oh, you guys, like, I hope you're ready, right? I hope you're ready and you're proactively engaged in some of these conversations, because if there are good networks that can support people outside of the health system, like we're going to need every ounce of capacity we can get to deal with this. And it's easy to say like, well, we just shouldn't do it. We're not prepared, but we have to do it because so many people are in crisis at the moment. But I think there is I view it as flattery. There's like a blind faith. If you talk to a cop, they have like a blind faith in healthcare. And they're like, if we can just get them to healthcare, everything will be fine. And I'm like, oh,
if you only knew. Yeah.
Do you know how hard it is inside of there? It's so hard. But I think that's another, like, there's this perception in the community of like, well, we're just going to get them to healthcare. And healthcare is not designed for that either. It's got to be.
I think that's very well said. By the way, I can't imagine we have a client, at least on the hospital side, that this isn't on the radar. I mean, I know it is. And I'll just be I'll be the consultant here. And I know this is not core. Well, from what I've heard and learned from you guys, I don't think this is at the core of what you guys are trying to do. I like the fact that you guys are coming at this from a desire to help people, which is how it should be. I'll be the consultant and say, there's a major financial component to this as well. Every client that we have, every organization that is trying to navigate this has to consider the financial impact. Payers are going to consider that. The government on the Medicare, Medicaid side is. This is one of those things too that has to be dealt with first and foremost because of working with people and individuals. But the financial challenge to this is becoming greater and greater. And having a partner, a solution, resources that can help close that gap is going to benefit that as well. And again, I know that's not y'all's first kind of focus and priority, but it's something we work with our clients on, because that's one of the things they have to navigate, right? So I just wanted to mention that. And I know you guys that isn't necessarily the greatest priority for you guys, but I think it is relevant for our clients and our listeners. So.
Yeah, no, but it's interesting because there's a whole discussion to be had, right, about the incentives and disincentives, and what Robert Wood Johnson now calls the wrong pocket problem, right? So you can do this intervention and you're saving money, but you're saving it for somebody else, and it doesn't benefit you financially. It's really kind of a sticky, and I hear it on both sides, right? The healthcare side, they grumble about the first responders, and for good reason. And then out in the community, people grumble about healthcare, right? They just want to bill, blah, blah, blah. And it really is just like a whole, like our payment structure has not quite adjusted to anything that resembles the real world.
Yeah. And I think they realize, at least on the hospital side, good intentions, right? They try, but I think even the majority of those entities or the people there would tell you, like, we're kind of just throwing good money after bad, or we're just kind of recycling, or we're going through this cycle, and they're losing money on some of these situations and some of these areas, but they're also not really investing necessarily in a long-term true solution. So that was one of the things that when you brought it to us, that really resonated with me, because they either they're in over their head, or they don't know what to do. They want to do something. They know they have to do something, but it's just kind of putting money in the wrong spot, and it's never going to pay off that way. And it's more importantly not going to truly help these communities.
It's interesting. I'm working on a planning project with Medicaid in a state, a Midwestern state. And we're looking specifically at people who are criminal justice engaged and Medicaid eligible. And I give them a ton of credit. These folks at Medicaid are creative and thoughtful and really in it to solve problems, not, to preserve their Medicaid budget. And one of the things that came out of this, when you think about the way systems are constructed, is that Medicaid saves money when people go to prison, because it shifts the costs of healthcare to the state prison budget. So the state it's fascinating. The state has a profound incentive to keep people out of prison, because then they can bill Medicaid for those services. Medicaid has an incentive to get people in prison because they don't have to pay for them. And so within the pipeline of the criminal justice system, you can actually see the incentives are fighting against each other, the back and forth. What that results in for a person, right? Imagine a mentally ill person who's, chronically engaged in the criminal justice system. That's the churning, right, that they experience. But we, in all of our systems, are well, look at that unstable person. They can't get their act together.
They're caught. Right? They're caught. They're stuck.
They're stuck. So it was really eye-opening to kind of see this play out in this analysis. And now the state Medicaid agency is saying okay, well, how do we make this right? Right? How do we, in the rules that we have, how do we fix this? Because we don't want to send people to prison because it's cheaper, but it's going to be really expensive for us if we have to pay for all this stuff out here. And that's the kind of stuff I think that's fascinating, that when you start getting into these intersection worlds, you start to see how the systems work and don't work. And money's a lot of it.
Well, you can't ignore the money side of it, but you have all these other kind of entities or constituencies that are stuck in between those misaligned incentives. You got the healthcare providers, they're kind of thrown in there. You got the law enforcement. They don't want to have to, they would rather a solution to fix it rather than just kind of continuing the dysfunctional cycle. So, and many others as well. So, but no, that's extremely interesting. And again, it goes back to, the system is not designed to just magically resolve and solve those challenges, nor is the financial structure set up to support it either, which I think goes back to that misaligned incentives discussion too. But Cam, to your point, no, we absolutely could have a second discussion. In fact, I think it would be really good because these are the types of things that are somewhat tangential to our core services of what we do, but very much related. And I like to highlight these types of things, kind of different angles, because it's problems or it's challenges that our clients are absolutely facing. They may not think of Coker first when they think of, okay, how do we start taking bites out of this particular elephant? But if it's something we can provide a connection to, that's absolutely a value to our clients, and then in turn a value to us and you guys as well, hopefully.
All right. A new consulting business line. Let's do it.
Like fun.
Yeah.
I really appreciate you guys coming on and talking about this. I could go on, and we could, I'm sure, talk about this for hours.
You can too, as you can tell.
and I genuinely want to continue the discussion. I'd love to have folks, if they do have questions, Cam, to your point, if they do have questions or they do just want to brainstorm, I would love to have you guys available to answer more of those questions, to have some more of those kind of brainstorming ideas that would be of value to our listeners and our clients, because again, I know this is something that is absolutely front and center on their radar. Please tell people where they can learn more about Cordata, understand a little bit more about where do we even start, and you guys working within a community, those types of things.
Well, I think if there's a listener to Coffee with Coker that has heard something today from Kelly and I and our discussion with you, Mark, that resonates with them, that something, has hit their heartstrings as a leader in their organization, and they think, wow, this is something I want to do to differentiate myself. I hear that, all the data problems, but I also hear that and know that there's a disconnect between the community needs and, what we're doing in my hospital or in my practice. And I'd like to talk to somebody. I'd like to brainstorm about what we could do differently. Because I think that's where, the really exciting things happen. So, that would be what I would say is if it's hit somebody, then let's have a conversation about it. We can, Mark, we can come back together with whoever that person is and let's brainstorm. You might know a lot about their organization also, and let's sit down and have a strategic conversation about what they can do to bring technology and innovation and some real community depth to the table.
Appreciate what you guys are doing. I appreciate y'all's willingness to talk about it. And I absolutely look forward to continuing the discussion in the future.
Totally agreed. This has been a really fun conversation.
Thank you, Mark. We enjoyed it.
Thank you.
We hope you enjoyed that episode of Coffee with Coker, and we thank you for listening. We want to encourage all of our listeners to participate and contribute in the podcast. So if you have any questions on any of the things we discussed in this episode, any of the topics that were presented, please feel free to ask us. Also, we welcome your feedback and suggestions. If you have any ideas related to the material we discussed in this episode, or in any episode, please let us know and we'll make sure to incorporate it. And if you have ideas for topics you'd like to hear more information about in future episodes, please send those suggestions to us. We would love to hear them and we'd love to incorporate them into our future episodes. You can find us online and on social media. Start with our website, and specifically the podcast is coffeewithcoker.com. You can also find that through the main Coker website at cokergroup.com. You can also find us on social media, Twitter at Coker Group. And then on LinkedIn, you can search for Coker Group and find our page and the page for some of our team members as well there. So you can find us and reach out to us a number of places. And then if you want to contact us directly, one of the best ways to do that, email feedback@cokergroup.com. That's feedback@cokergroup.com. And again, we'd love to get your feedback, and we'd love to encourage everyone to subscribe to the podcast so that you can be notified when future episodes are released. We look forward to the next episode, and we look forward to getting your suggestions and feedback on this episode. Thanks for listening, and we look forward to speaking with you again on future episodes.